Welcome to our webinar. Bienvenidos. In the name of the National Latino Behavioral Health Association and the National Hispanic and Latino Prevention Technology Transfer Center, we welcome you to today's webinar titled Suicide Prevention, Identifying and Modifying Risk Factors that can lead to suicide attempts in Latino youth. We are happy to present this webinar as we celebrate the Hispanic and Latino Heritage Month and honor the Suicide Prevention Month. My name is Dolca Michelle Zelaya. I am the Program Coordinator for the National Hispanic and Latino Prevention Technology Transfer Center. I will be your host for today's webinar. Before I introduce you to the next presenters, here are some brief instructions about today's webinar. This webinar will be recorded and archived for future playback. It will be also recorded in Spanish and also in Portuguese and posted on our website. A copy of today's presentation will also be made available after the webinar. The lines will be muted throughout the presentation so as to minimize background noise. When we get to the QA portion of our webinar, you will have an opportunity to ask questions to the presenters by clicking the QA box. We also be asking you to fill out a brief survey at the end of this webinar. This satisfaction evaluation is important to the work that we do and provide us with the opportunity to improve our training efforts. Although we are not securing continuing education credits for this event, we plan to do for future events. A certificate of completion will be sent to you after this webinar. So let's begin. Let's start by introducing the National Latino Behavioral Health Association, NALBA. NALBA is a nonprofit and is located in New Mexico. The mission and goal of the National Latino Behavioral Health Association is to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. Next slide. NALBA was established to fill a need for a unified national voice for Latino populations in the behavioral health arena, and to bring attention to the great disparities that exist in areas of access, utilization, practice-based research, and trained personnel. NALBA's executive director is Mr. Fred Sandoval. Our objective is to provide national leadership on mental health and substance abuse concerns of the Hispanic and Latino community. NALBA's policies priorities are targeted capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of counselors, therapists, and other behavioral health practitioners, funding for co-occurring disorders on alcohol and substance abuse, opioid crisis in the Latino community, and suicide prevention. Now, allow me to introduce to you our Prevention Technology Transfer Centers. Our PTTC is part of the TTC network, a multidisciplinary resource for professionals in the prevention field. Established in 1993 by the Substance Abuse and Mental Health Service Administration, SAMHSA. The PTTC network is comprised of 10 domestic regional centers, 2 national focus area centers, and a network coordinating office. Together, the network serves the 50 U.S. states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and the Pacific Islands of Guam, American Samoa, Palau, the Marshall Islands, Micronesia, and the Mariana Islands. Our center has a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. Our PTTC is staffed by Dr. Pierluigi Mancini, our projector director, and Priscilla Yamasi, the executive administrative assistant, and myself, Dolca Michelle Zelaya. Now, it is time and an honor for us to introduce our esteemed presenter for today, Dr. Santiesteban, Daniel Santiesteban, and Dr. Maite Mena. Dr. Daniel Santiesteban is a clinical psychologist who received training at Rogers University, University of Miami, and Bellevue Hospital, New York. He is a professor emeritus at the University of Miami School of Education and Human Development. Dr. Santiesteban research focuses on adolescent and family therapy, culturally informed treatments, and family therapy trainings. Dr. Santiesteban is the developer of an adaptive, evidence-based family therapy called Culturally Informed and Flexible Family Treatment for Adolescents, CIFTA. CIFTA is one of the few evidence-based treatment originally designed for Latino families and being utilized in communities agencies around the country. Dr. Maite Mena. Dr. Maite Mena is a research assistant professor and a licensed clinical psychologist at the University of Miami School of Education and Human Development. She has an extensive experience in working with minority populations, experiencing health disparities, and implementing programs and evaluating their outcomes. Over the past 15 years, Dr. Mena has focused on identifying the unique need of the Hispanic and Latino community and has specialized in developing and testing culturally informed family therapy for minority populations, CIFTA, focusing on families affected by substance abuse, co-occurring disorders, psychiatric disorders, self-harms, and cultural stressors. Dr. Santiesteban and Dr. Mena, we are so happy to have you with us this afternoon. Thank you so much for accepting our invitation, and please proceed with your presentation.
Thank you so much. We have a very special thank you to the PTTC, NLBHA, and to SAMHSA for supporting this webinar on a topic that is concerning and alarming for providers and for family members. There's very few behaviors that family members and parents worry about and suffer through more than through suicide behavior in their adolescence. Also, in these complex and challenging times of COVID, I also want to send a very special thank you to all of you who serve adolescents and families. You've had to move services online, and we appreciate how difficult that has been, even as your own lives have been disrupted. So thank you. On this roadmap for what we will talk about today, you see 4 general categories or sections, clarifying definitions, talking about the prevalence of the problem. We're going to talk about identifying risk factors and the role of culture, the interaction of culture with risk factors. And finally, we're going to talk about how to modify risk factors so that we can prevent suicide behaviors. At the end of the second section on prevalence of the problem, we'll take a short break so that we could talk about questions that you have. At that time, we'll receive questions and try to answer any questions you have about the first 2 sections. And then we'll move on and have a question period at the end of the 3rd and the 4th segments. That way we can stay connected and interacting well. We thought that it was very important to begin with definitions around the umbrella of suicidality. We often hear the word suicidality, and it's really an umbrella for a number of different and distinct behaviors. The first category that we wanted to talk about is self-harm. you'll often see NSSI that refers for non-suicidal self-injury. And basically, this is self-inflicted injurious behavior, such as cutting, punching self, pulling hair, in the context of seeing evidence that there is no intention to kill the self, right? So in self-harm and non-suicidal self-injury, the person does not have the intention of killing themselves, even though some of the behavior may be similar to behavior that you see in suicide attempts. Second, we have suicide ideation, which have to do with thoughts in which inflicted death is a desired outcome. And of course, suicide ideation may or may not come with a plan. And that's a very important distinction that we'll talk about in a little bit in terms of risk. Third, we can talk about suicide attempts, self-inflicted injurious behavior with a non-fatal outcome in which there is an intent to die or to stop consciousness. And finally, of course, we have actual suicide. We feel that it's very important to keep these distinctions in mind because they're often thrown together and used interchangeably. But in fact, when you're working with adolescents, they can be very different. A self-harming youth can be very different from a youth who has been attempting suicide. In the self-harming category, in fact, what kids report is that they often cut in order to reduce intense pain or great feelings of frustration. They actually report that the act of cutting actually brings them back to the moment and reduces their level of distress. And again, it's important to understand that they are not contemplating death or loss of consciousness. In the bottom two categories where you see self-ideation and suicide attempt, there is the idea of death or stopping consciousness. It is important to separate ideation from ideation with a plan, which of course increases risk, and then ideation with a plan and a history of previous attempts, and other facilitators such as gun availability or substance use. Each of these additional behaviors continues to increase risk of an actual attempt or of actual suicide. There are really two important take-home messages that I'd like to make here. The first is that some of these kids and these categories are unique. The motivation and the reasons for the injurious act for the self-harming youth is very different from the suicide attempting youth. And if you're going to be helpful to these kids, it is very important that you truly understand the reasons and motivations for the behavior. The second take-home message might sound contradictory to what I just said, but actually complements it. Although these kids can be distinct, they can also move from one category to another. That is, because you have a self-harming youth, it does not mean that that youth will not attempt suicide at some point. And so understanding how a youth can move from one category of behavior and motivations to another is also a very important piece of our work as we're working with these adolescents. Just as an example, even though self-harming youth are very different from suicide attempting youth in their reasons for their behavior, research shows that self-harming youth are actually 7 times more likely to die from suicide than their counterparts who are not self-harming. So what that means is that the self-harming behavior does create a risk for these youth moving over time and over circumstances to being a suicide attempting youth.
So now we want to move on to talk a little bit about the prevalence of the problem. So when we think about the extent of what's occurring with these suicidal behaviors, we know now as of 2017, and now some latest figures have come out for 2019 from the CDC that tells us that suicide is the second leading cause of death among adolescents. We also know that between the ages of 13 and 19, there are almost 3,000 deaths in the United States in the last year. When we think about intervention, and we're going to talk about this more deeply later on, we think that, you know, how we want to think about it is that interventions designed to prevent later morbidity and mortality as youth progress. So that's what we want to stop. And that can take on many forms and at many different levels. So let's take a minute to complete the poll question. So which of the following is true? And please check all that apply. Okay, so there we can see how everyone responded. And it looks like everyone it's close between males completing suicide 3 to 4 times more than females, and females attempting 3 to 4 more times than males. So let's talk a little bit about that. So what we see is that when we look at rates of self-harm or non-suicidal self-injury, approximately 17.6% of youth are identifying as engaging in self-harm. It's more common in females, and as adolescents get older, the rates decrease. And something important to note here is that even though we're looking at self-harm at a much higher rate now, and there's lots of investigation in this area because of the severity of the problem, findings are never entirely accurate because of the stigma and shame that surround this behavior. And so the actual rates are likely to be much higher than those that are currently reported. So something to keep in mind when you're looking at rates of self-harm. When we think about suicidal ideation, this is quite common. So up to 19% of youth seriously consider suicide. Attempts are 3 to 4 times more common in females, and an actual suicide is 3 to 4 times more common in males. So we want to take a brief break just to answer a few questions that have come up. I know that I see one question that's come up that we want to take the time to answer now before we move on. So the question is, how do we differentiate between these definitions and the adolescent who says they feel like dying, but engage in none of these behaviors?
So that's a great question, differentiating these categories. So the minute that they say that they feel like dying, they really move away from the self-harming category and towards the ideation category, right? Ideation or attempt. And so then it's a matter of whether there has been a behavior that is an attempt. So self-harm that occurs, self-injury that occurs with an intent to die, therefore becomes an attempt. Now it's very important that, you know, and it's clear that one of the major distinctions is intention, right? And evidence, right? What evidence do you have that this has happened? But sometimes that's unclear. Right? It's not always the case that an adolescent can talk about that as clearly as possible. And the safest route is probably to assume that there might be an intent to die, right? Rather than assume that there's no intention to die. So I think that's probably the safest if the evidence is unclear, if it's unclear whether there's an intent to die, you have to assume that.
And something else to take into account, I think, is when you are, you know, having this conversation with an adolescent, is to really take the time to understand what they're saying. So if a youth is saying, I feel like dying, slow down and really take the time to understand it. Don't jump to assume that it's ideation. Sometimes youth use those terms because they're in deep despair or there's a sense of hopelessness. And so you want to really just take some time so that when you want to move to their serious ideation here, are they hitting all of the markers for really having a plan and thinking through that this is a viable option for them. So it's really about taking your time to get to know what is it that they're actually thinking and feeling and where is it coming from. Let me see here. We have a few other questions. So somebody brought, let me just make sure I don't miss any. So we have differences. Will we speak to differences in suicide ideation and attempt based on sexual orientation and or gender identity in Latinx youth? Yes, we'll talk about that shortly. But in terms of rates, they are at the high LGBT youth who are Latino and identify as LGBTQ youth are at one of the highest levels of risk for engaging in these behaviors. When we think about an actual attempt, they are second behind American Indian and Alaskan Native youth. Another question is, there are people who don't present any of the above and will act on impulse and die by suicide, correct? Yes, that absolutely can happen. There's individuals who show none of these risk factors, and nobody really saw it coming. So yes, that does occur. I believe there was one here on the chat that we may have missed. Do you find that more attempts come from broken homes?
We're going to talk a little bit about family context in a little bit, so I think we can respond to that.
Okay, great.
Fantastic. Let's move on.
So we're going to move on now. I think hopefully we got, if you feel like we didn't answer, oh, I'm sorry, we have one more. Is that okay? Is there a difference with adolescents that never have self-harm attempts and just have suicidal ideation and no planning of means, or is that incorrectly labeling self-harm as ideation? So if there is no planning and no means, then it wouldn't be labeled as self-harm. If there's somebody who's thinking about wanting to engage in self-harm or wanting to die, then that would be classified as suicidal ideation.
Good. Let's move on to next categories. We're going to talk a little bit about identifying risk factors and the role of culture. And you can continue to send your questions, and some of them will be answered as we go forward. Here's a second poll question. Which of the following can trigger or facilitate a suicide attempt? And please check all that apply. Okay, so I see here that most people have gotten this correct. The first one, asking the adolescent questions about suicide risk, is a very important one, because that's typically a myth that might stop a practitioner from doing the right thing and asking about risk. So it is a myth that if done correctly, an interview that asks about ideation and behavior, self-harm, and suicide attempts does not increase the amount. Now, substance use is a potentiator. Just like it can potentiate domestic violence, it can also potentiate self-harm behavior. That's a very important one. And we'll talk a little bit more about that as we go forward. The last one is an important one in terms of shows that talk about suicidality. There is a concern that some of the shows that sort of glamorize or make sort of intriguing suicide behavior can actually be linked to behavior increases in attempts by adolescents. And that there is a considerable amount of evidence that that can happen. So we think that that's an important one to keep in mind. So this particular slide has a good amount of information that we've already talked about on the left side, but I'd really like to focus on the graphic on the right side. And if you look at self-harm and suicide behavior risk factors, and the next slide will have even more of them, but these are some that we think are particularly important. Depression is in orange there because it is by far one of the risk factors that has come out most in terms of risk factors for self-harm and suicide behavior. But you also see substance use, which we just discussed, previous self-harm, so that if an adolescent has previously shown self-harm and a suicide attempt behavior, they are at increased risk for a second suicide attempt. And of course, history of trauma, sexual, physical abuse, and different types of history of trauma have been shown to increase risk. The next category is also an important one for us. And one of the ones we see there is Latinas. Although in the past year, when you look at the reporting and the rates, Latinas do not appear to be higher than their counterparts, than their non-Latina counterparts. If you look over the past decades, Latinas were indeed among the highest in terms of self-harm and suicide behavior. And that led a number of our outstanding colleagues, such as Luis Zayas, to do some great research on exactly why our Latinas had higher risk rates. We also see here LGBTQ teens and multiracial teens. And when you look at the literature again, each of the kids in those categories have higher rates of self-harm and suicide behavior. Now, it's important for us to think about this, right, in our work. There's nothing that I know of. There is no genetic predisposition that I know of in Latinas, multiracial teens, or LGBTQ teens. There is nothing about them as individuals, except that they often live in a context, in an environment, in a society in which there is a good amount of marginalization, racism, discrimination, and that interaction, right, between the individual and their context, whether it be family, and we'll talk about that in a bit. There could be family rejection for some of these kids, or larger environmental, societal, contextual sort of stressors. Those are some of the major contributors to why some of these kids are at increased risk for self-harm. And in a little while, we'll talk about the importance of measuring some of the stressors that these kids experience in their day-to-day lives, and how it's important for our services, right? For our prevention and treatment services. There's another comment I want to make about the substance use, previous self-harm, and history of trauma risk factors. It's important to realize that these are not static risk factors, right? For example, a child can start with a history of trauma. The moment that they have a suicide attempt, right? Now they're in the previous self-harm category. Their risk for a future attempt has just increased, right? So there's a fluidity in terms of risk of youth. If a youth begins for the first time to use substances or increases their use substantially, again, their risk is increasing. It's a fluid increase. Fortunately for us, it can happen conversely, that if, for example, in a youth that has all of these risk factors and is also using a considerable amount of substances, if we can reduce that use, we are in fact decreasing their risk factors. So it's important to understand the fluidity of this as we move forward and try to help our youth in our programs. We have here listed a more comprehensive list of some of the risk factors that have been talked about a considerable amount in terms of suicide-related behaviors, depression and anxiety. Borderline personality disorder is an interesting one. By definition, there's often self-harm in that category. There is some controversy about whether borderline personality disorder can be diagnosed in an adolescent. And you have arguments on both sides. I think most of the evidence is that you can see a cluster of behaviors that include impulsivity, dysregulation, et cetera. And so it's an important one for us to consider. Previous attempts we've talked about already. Emotion dysregulation is a very important one. There was a question earlier about impulsivity. And impulsivity is a very important set of behaviors, and emotion dysregulation is something that has really been highlighted by, for example, Marsha Linehan in her dialectic behavior work. It's a very, very critical risk factor. Substance use, poor self-esteem, we've talked about. We just talked a little bit about things like contextual things like bullying and marginalization, history of abuse. And as we move forward, we're going to talk a little bit more about some of the family issues that can create a context for risk and conversely for protection, right, in the family. But in terms of risk, there could be a lack of family connectedness. We see that issues of acculturation and cultural dissonance can play a role, and we're going to talk about that more in the next section. And a very interesting one is the one of migration experience. Although we won't talk about it today, Dr. Mena has actually done some very interesting research on youth who have been separated from their parents due to migration process, right? Parent and child separation during the immigration process. And she's been able to show that particularly the females show a good amount of depression, and that there could be breakdowns in the relationships in the family that really need to be mended and repaired if we're going to have success. And I think that in a case study towards the end, we're going to talk a little bit about that. But that whole piece of immigration-related separations can be a very powerful experience that we should be aware of and be able to work with. I'm going to talk, here's a simple list of triggers, because we want to separate sort of what the underlying conditions are that the youth experiences from sort of momentary triggers. And this is a not comprehensive, but some of the main ones that kids tend to report, such as breaking up with a partner, an act of aggression, racism, bullying, harassment that happens right before the attempt or other self-harm behavior. Often it involves a family member, so you see either alienation from loved ones or an actual incident, a fight that happens right before the attempt. And then also you see often death of a friend or a family member. And if we were going to list some of the warning signs, these are some of them. Not all, but some of them. Threats of talking or hurting, or killing self. Expressing no reason for living. That reasons for living is a really important one. In fact, many of the measures that are used to try to understand risk in kids as well as in adults look at whether there are reasons for living. Marshall Linehan, again, with dialectic behavior therapy, talks about having a life worth living. And if an adolescent can't define what their life worth living is, they are at increased risk. And you'll often see as a warning sign them talking about that, not having a reason for living. Agitation, and I underlined inability to sleep because there is an increasing literature on the fact that kids that self-harm and attempt suicide have often been shown to have a major problem with sleep right before the attempt. Hopelessness is a key one, obviously. Withdrawal, recklessness, mood changes, and increased drug use. These are all major warning signs that you might want to look for. In terms of looking here at some of the contextual factors, and we talked about this, about the importance of contextual factors, and moving away from looking only at intrapersonal, within individual, right? Within individual sort of risk factors, to look at more interpersonal things. That's where the role of culture and family and context and school, right, can come in. Individual behaviors are strongly impacted by the system in which kids find themselves. And again, Luis Zayas has done some very interesting work on looking at the role of culture and context in terms of youth suicide. I want to give you an example of something that we talk about often in the literature on acculturation, and that is the gap between youth and their parents on acculturation. Youths tend to acculturate much faster than their parents. And so what happens is that many behavior problems in youth have been linked back to acculturation gaps between youth and parents. We've seen that with depression, we've seen that with substance use, etc. And what happens is that a good amount of literature has found that as the discrepancy in acculturation between youth and parents increases, so can conflict and so can breakdowns in some of the family factors that we consider protective factors, right? Parent involvement, good communication, affection. Those things may break down when you see this widening gap on acculturation, and that increases over time. And that is clearly something that we can see in youth, in families, and that we can actually work on modifying. So we've had the honor of working with an exceptional expert in the field, Dr. Richard Cervantes, who's actually the developer of the Hispanic Stress Inventory. And we were able to conduct some research on Latino adolescents and look to see what kinds of stressors are associated with suicide-related behaviors and thoughts. Again, we think that it's really important that we be able to accurately measure the stressors that kids and families are experiencing so that we can adjust our services to those needs. Those are the things that are true in the daily life of parents and kids. And an intervention that does not address these things, we believe, sort of missed the boat. So what did we find? For Latino boys, we found that acculturation gap stress, the gap that I just showed you that we found in other parts of the literature, was associated with suicidal thoughts, and discrimination stress was associated with suicidal thoughts and self-harm behavior. Again, think of discrimination stress. The youth are reporting that they experience stress due to discrimination. Dr. Cervantes and the team looked separately at the girls and to see if there were unique sort of experiences that might be related to the suicide-related behaviors. And they found that in girls, family drug stress, stress about the use of drugs in the family was associated with suicidal thoughts. Acculturation gap stress, again, family drug stress and immigration stress were all associated with self-harming behavior. So we think that this is a very important way to think about, consistent with Dr. Zaya's work, some of the stressors that may be associated with suicide-related behaviors.
So let's talk a little bit about, and this is partly related to the question that was brought up earlier, but when we think about LGBTQ youth and risk, when we think about this gender minority group, we know that the risk is often much higher. 2 to 7 times more attempts show for this group. And it's often much higher due to increased discrimination, marginalization, and rejection. And a lot of that comes from within the home, so rejection at home, from family members, from peers, and even from others. So it's really important to think about the link to culture again when we're thinking about context here. In some cultures that have a more difficult time accepting LGBTQ youth, here's where we see the frequent family rejection, often to the point where youth are left homeless. They're kicked out of the family, they're kicked out of the home, and this is the largest growing homeless population that we have right now. And again, when this happens, in children that have a family orientation that endorses the importance of family, right? So we think of familism for the Latino culture, this rejection can be even more pronounced. And again, as I mentioned before, when I was answering a question, the rate of the reports of an actual suicide attempt in the last year for Latino LGBTQ youth was second behind American Indian and Alaskan Native LGBTQ youth. And as we mentioned earlier, when we showed the slide with the risk factors, multiracial teens were listed as a risk factor, and they are actually number 3 on that list with the highest rate of suicide attempts. So let's finish with this polling question, and then we'll get to some of the other questions that have been asked. So which of the following is true regarding how culture can impact services for suicide prevention? So all of the responses are in, and everyone's pretty much split between all of the answers, as you can see. And the answer is that they really all apply. So Latino parents really can feel more stigma related to self-harm and suicide, and that can impact attending services or seeking services. Latinos may be less connected to systems that provide services for youth. They may also feel services aren't designed to address issues that are important to them. And they have a harder time with acceptance of an LGBT youth, as well as conflicts in the family that may be present because of differences in acculturation and are actually escalating to family conflict.
That was a little bit of a trick question, but we thought it was important that we realize that all of these are ways in which culture can impact.
That's right. So let's take a brief moment to answer. It looks like we have a lot of questions that have come up in this previous section. So bear with us as we, so I just see a comment that somebody tried to check more than one, but it didn't work. So yes, it seemed like it was a trick question, but they did all apply.
So I can start with one question, and maybe Dr. Mena, you could take a look at some of the other ones that are coming up. One of them is, for acculturation gaps, how do we present this concept to parents of family members of Latino teens that we might be working with? It is a major barrier since the level of education might be different. And one of the things that we really try to address when we're talking about this gap is to normalize it, right? It's to be expected that an adolescent is going to acculturate more rapidly. Your child, your son, your daughter is not necessarily rejecting your culture of origin, is not necessarily rejecting your language. They are going with the flow of what acculturation tends to be. Now, that does not mean that we can't work on helping them to appreciate the importance, right, of knowing, of honoring their culture of origin, and to have discussions with parents about the benefits, right, and the strengths of their culture. But it is important, we think, to normalize it so that it's not an individual choice to reject something about the family of origin. It is a very natural process that any person put in a new context will begin to show the behaviors, beliefs, worldviews of that larger context. Great question.
I want to add just one bit of information to that question, which is that be aware, and you know, you all are most of you seem to be clinicians based on the chat, but it's possible that this acculturation gap is driven by the adolescent, in the sense that when there has been a separation, oftentimes the parents come to the United States first and the adolescent stays behind in the culture of origin. And the adolescent comes over to be reunited with the parent at a much later date. And when they arrive, there are times, and we are seeing this in our clinical work with SIFTA, where the parents are more acculturated and have acculturated to the United States, and the adolescent is experiencing difficulty. Even being here 1 year, 2 year, we're seeing youth who are not becoming comfortable here in the United States. They're having trouble with the language. And that gap is coming from the difference that the youth is just not happy here. So I just want to open the possibility to be sensitive to that might be occurring as well.
So another question was, what part does a youth's upbringing play in overcoming marginalization and suicide behavior? Maybe a positive upbringing, despite challenges in Latino minority communities, prevents suicide. And this is a very, very important point. And one of the things that we always talk about is there's one thing to consider is risk factors, but we also have to talk about protective factors. And the reason that we really enjoy working with Latino families is because we get to identify and enhance all the protective factors that are there. Marginalization and discrimination, for example, are things that parents can help a youth with, right? To help them as part of their parenting, how can you best handle that, right? Let's talk through ways in which you can address it. Parents can, of course, actually serve as advocates in contexts, right? Like schools, where there might be discriminatory behavior. But at the very least, just through communicating and talking through, supporting, right? Validating the feelings of the youth, they're already having a huge positive impact on the youth, so that the act of discrimination does not lead with the same strength to some kind of behavior such as suicidality.
Let me go back quickly just to answer a few that came before while we started this section. Do some people have suicide because they're angry, or how angry they get? So this was part of that slide with the risk factors and all of the circles. And also we talked about emotion dysregulation as being a risk factor. So absolutely, if there's intense anger that is not able to be controlled, and the coping mechanisms are not in place, then yes, that can certainly lead to suicide. Do you recommend a referral for counseling in regards to the first two categories? I assume that's the self-harm category and the suicidal ideation. Those are, again, risk factors as you move down the line towards actual suicide attempts and suicide. So it is a good idea from a prevention perspective to start with treatment sooner rather than later.
You know, and in a little bit, we're going to talk about the different levels of prevention, for example, universal and indicated prevention, for example. And we can talk about some of the ways in which even a universal sort of intervention can talk to adolescents, create awareness about the role, right, of anger, how to handle it, and how to prevent it from being a trigger for self-harm.
Do some people literally kill themselves when they get bullied or harassed? It's possible. Being bullied is, and harassment and discrimination are risk factors, so that is a possibility.
If you think about the fact that for many kids, self-harm or suicide attempts are a way to get away from pain, right? The fact that they're hopeless that things will ever change and that they need to move out of that life that they have, yes, that repeated, particularly chronic abuse, marginalization, bullying can indeed lead to suicide. We have a number of questions that are specific to a child or a family, and we don't think that this is the best forum to talk about that. We would love for you to have our contact information, and we could certainly take offline some of the contacts and calls, so that to the PTTC team, if you can please facilitate that for us, so that no one is left without information that they need. I'm aware that there is information going up on the chat on the Prevention Lifeline, and that's very, very important for everyone to have that kind of information. And actually, towards the end of this talk, we'll talk a little bit about safety plans. What do you think?
Sounds good. We're ready to move on. So let's talk now about modifying risk factors to prevent suicide prevention. So we're going to talk about this at different levels, and we're going to think about it from a prevention perspective. And as you all know, prevention can take many different forms. We think about universal prevention, selective prevention, and indicated prevention. When we're talking about universal prevention, we're really talking about something that's going to seek to reach all people. And this is something that happens very early on before there's any signs or symptoms, right? So strategies can include things like mental health policies, awareness raising and education. A lot of these take the shape of campaigns. They can be media campaigns, school campaigns, community campaigns, improving access to healthcare. And when we're thinking about the Latino community, as we are for this webinar, thinking about how we can improve access to culturally appropriate healthcare, mental health, behavioral health. And then general universal population screening. So that is very important and something that we've been talking a lot about in the field now, that it's something that's really important, especially for behaviors that we're talking about and symptoms that we're talking about today. If we integrate a universal screening where everyone gets screened, we're more likely to be effective at identifying individuals who might be at risk. And this is taken on a lot in other initiatives. For example, one that SAMHSA is very committed to, the screening, brief intervention, and referral to treatment. Selective prevention, when we think about selective preventions, here we're thinking about already identifying individuals who have some level of risk. So there's a sign. And interventions here include things like gatekeeper training for doctors, counseling of individuals, so actual mental health behavioral counseling for individuals who have been identified through screening or assessment as being at risk, crisis helplines that are up and available for individuals to utilize, and then interventions for vulnerable individuals, so those who are experiencing severe stress or severe circumstances. And then lastly, indicated prevention. And these interventions include management and assessment and management of mental health disorders that are associated with suicidal behaviors. We think about actual intervention, coordinating community supports, and psychosocial follow-ups. So let's just, give some more. I'm going to give a few more specific examples for each of these. So when we think about actual suicide prevention in the arena of universal prevention, here we want to prevent the onset. So there are no symptoms here, right? There are no symptoms yet. So we want to prevent the onset of suicidal thoughts and behaviors by diminishing the effects of individual and environmental risk factors. So if we think back to the conversation we had earlier when we were speaking about what are some of these risk factors, and we talked about some that were intrapersonal, so within the individual, like depression, anxiety. And we also talked a lot about things that occur in the context in which the youth lives, in the environment, in the neighborhood, in the school, in the family. So that's what we want to look at here to target in order to prevent onset of these symptoms. And some examples, and there's many, but these are just a few. Fostering resilience in youth, promoting family, peer, and community connectedness and support. So this is very important. A lot of literature has told us that this is important. Having access to culturally appropriate mental health and behavioral health care. And then promoting participation in physical activities such as team sports. And this is one of the universal prevention strategies that has actually been shown to be connected specifically to Latinos. And so when we think about universal prevention for Latinos, Latino youth, this is an area that we really want to think about. So getting a little bit more specific in terms of indicated prevention, this typically includes the treatment of major presenting symptoms, as I mentioned before. So thinking of treating depression, anxiety, emotional dysregulation and impulsivity, substance use, and other co-occurring disorders. And examples of evidence-based interventions that exist in this arena are dialectical behavior therapy for adolescents, CBT, and there's a few different forms of CBT that have been investigated and are showing promise, and systemic family therapy. Something to note with the dialectical behavior therapy is that it's been shown to be very effective. It's the only intervention that shows is well established in terms of evidence. The skills that were developed by Marsha Linehan for this intervention were originally for individuals who were diagnosed with borderline personality disorder and substance use. And since that time, which was many years ago, several iterations of the intervention have been tested and modifications have been made for adolescents. And we are still, two things to note for dialectical behavior therapy. One is that there are not many studies where the entire group of individuals or a large majority of the individuals in the study were Latino. So we need to see how, when we have a primarily Latino sample, if the results hold. And second, many of the studies, actually all of the studies, contain the majority of the samples, majority female, upwards of 95%. So the question of males and whether this is effective for male adolescents is also an important one to think about. And then suicide-specific brief interventions is an area that has been being studied much more recently now. And there's a big movement towards trying to intervene immediately in acute care settings. So we're thinking about crisis centers, emergency rooms in the moment. And so what we know so far, and this is again an emerging field, but motivational interviewing has a lot of evidence for its effectiveness. A teachable moment brief intervention, which is a one-time intervention 2 days after an attempt, shows promise. Crisis response planning and safety planning is an evidence-based brief intervention. And then the attempted suicide short intervention program. And when we think about, I want to take a minute to spend a minute here just talking about a safety plan really quick, because sometimes this can be misinterpreted as to what it actually is. Sometimes we talk about a suicide pact. So there's times when a client comes into our office and there's suicidal ideation. And so the clinician will create a suicide pact, meaning that this individual is not going to take any steps towards an attempt or engage in any behaviors that are related to self-harm. But this safety plan, this intervention is more than that. It's different. It doesn't, it really specifies what steps you want to take, and there's 6 specific steps that want to be outlined within this safety plan. So one is related to addressing how to make the environment safe for the adolescent. So how do we get rid of knives? How do we get rid of dangerous medications, firearms, guns, etc. Next, we want to identify what are the most important and commonly occurring warning signs, thoughts, and feelings for that youth, and write them down. Then you want to talk about internal coping strategies. What strategies actually work? And it's not about just suggesting and saying, oh, you know, so let's do some deep breathing. That doesn't work for everyone. Let's take a walk or listen to music. That doesn't work for everyone. So this step is really important because it really requires to work with the adolescent to figure out what might actually be a viable option for them in the moment when there's high distress. Number 4, identifying people and situations that can help. And this is just not like, oh, I think my mom can, or my best friend, or my neighbor. It's literally writing them down, having their contact information, their phone number, their address. So there's like a very clear plan. These are actual, again, very viable individuals who can offer support and that they are most likely to reach out to at the moment of distress. Identifying people who can be accessed and talked to when things get a bit more advanced, meaning that there's, again, high distress. This individual is very sad, very depressed. There's high suicidal ideation, and there's an inability to cope with that distress. And again, here you want to make sure that you have more than one option. You want to have as much support as possible as a theme. And then provide the names. The last step is to provide the names and numbers for hotlines, treatment or community centers, crisis centers, emergency rooms that can be contacted during a crisis moment.
I want to reiterate something here in the 5th point, the fact that you need more than one person, 1 or 2 people to reach out to become, so that they don't become overwhelmed. If you think about an adolescent who is at risk and it may be suicidal and decides that there's this one great friend that they're always going to go to, imagine what happens when that person is overburdened, right? When it's too much to have that burden and responsibility and it's too painful to be there and not be able to help, right, at all times. If that person pulls out, which is a very normal response, then the adolescent is really left in a crisis, right? And so it's really, really important to help the adolescent think through that there really has to be more of a network because it is unfair and not feasible for one person to be the only person there. So you know, our specialty is family work and indicated prevention. So we want to talk to you a little bit about, you know, as we finish here, some of what that looks like, right? And we talked about, you know, the fact that one can look at intrapersonal factors in any adolescent that is self-harming or attempting suicide. And, you know, you might see some of these kinds of things, right? An adolescent looks depressed, and you could see that in his face, right? You could see that as a possibility. Maybe they're high, maybe they've been using substances, increasing their use. Maybe there's impulsivity, sadness, angry, low self-esteem. And those are all reasonable things that you would look at, think about them as risk, and perhaps even think about intervening in. But we talked about the importance of context, and what we tend to see is an adolescent in the middle of a context. And in this picture, the way we zoom out now, it's in the middle of a context of a family with conflict. And this is what we tend to see when we move from individual work to family work. And the reasons for the conflict in the family can be all of the things that we've talked about, because the parents are also stressed and the victims of discrimination and the victims of economic stress and struggling with acculturation. And so, you know, when you look at, instead of an individual or a family, you see things such as this. Hopelessness in the child about conflict in the family. Confusion about who to support. That's a tremendous burden to have to feel like you're in the middle of something and you have to support one or the other family member that you love. And in the case of many of the kids we work with in the middle of these conflicts, they're scared that they may have to step in to protect someone. These are all the types of issues that when you zoom out into a contextual perspective, you can see these kinds of things. Now, as we mentioned before, we can also see protective factors, and that becomes something that you work with as well. So the intervention that we've developed is called Culturally Informed and Flexible Family Treatment for Adolescents. We call it SIFTA. It's a mouthful, and the reason that we kept that long title is because we didn't want to forget that we have to be culturally informed. There are many great treatments out there, and even some of the ones that Dr. Mena talked about, like dialectic behavior therapy, it remains to be answered whether they are effective with Latino youth and families, and whether they have upfront, right at its core, the kinds of cultural factors that we think are important. And so we wanted to make sure that we had it in our name, culturally informed and flexible, because no two families are the same. There is no one size fits all. And then family treatment for adolescents. Our intervention has individual work, which includes motivation enhancement and motivational interviewing, goal setting, for example, and working through identity issues. We've talked about sexual orientation, gender identity, race, ethnicity, right? There's all kinds of identity issues that adolescents can work through. And we do that in our individual work, but our treatment has all of these components. So it's not that we choose one individual therapy or family therapy. They have to work together. Psychoeducational modules are important because they can address things like acculturation and immigration-related separations. And going back to one of the major risk factors that we saw, some of our best modules work with things like emotion dysregulation and how we can use some of DBT's modules on interpersonal effectiveness, emotion regulation, to make the work more effective. And then family therapy, as I mentioned, reducing triggers such as rejection, but also enhancing protective factors, parental involvement, advice, guidance, affection, validation, etc. And at each of these steps, we've worked through how cultural factors should be integrated into the work. At the bottom there, you see just some of the publications that we've had on that show the efficacy of it, and one of them is actually a computer-assisted intervention. So we leave you with that. And we didn't want to say too much about that, but Dr. Mena is going to move on to a case study just to give you an example of how this might work, and then we'll end there.
So the case study that I'm going to talk about is a case that we had in our SIFTA intervention, and it was a 15-year-old Latina female, Latina, who was presenting for self-harm behaviors, cutting that had started at the age of 7, with a sexual abuse history, and had experienced an immigration-related separation from the biological mother. The family makeup is that the adolescent has a younger brother. Biological father was never involved. A close male friend of the mother had sexually abused the adolescent since the age of 7 for a period of years. At that time, the adolescent began to self-harm. When the adolescent was around 12 years old, the mother left the country of origin and came to the United States, leaving the girl and her brother with the maternal grandparents. 3 years later, the mother, the adolescent, and the brother were reunited in the United States. The mother had remarried, and the stepfather was a part of the family. This was a difficult time for the family. The mother immediately began to want to take on the parental role again and parent the youth and her brother and to set rules. However, the adolescent wasn't accustomed to this. She was used to being in the parental role with her brother in the country of origin, and was really not open to accepting the mom as her parent, given what had happened in terms of the sexual abuse and the separation. So this caused a lot of family conflict. There was also a lack of connection between the youth and the mother, and very little communication. The entire family presented for treatment: the mother, the stepfather, the brother, and the adolescent. And this was the first time that they had ever had an encounter with mental health services. The mother and the stepfather were very motivated to begin treatment, although the adolescent had no motivation for coming to treatment, and basically said from the start that she was only coming because her mother was making her come. And so that's just a little bit about the history of the family. And I wanted to talk specifically now about the SIFTA interventions that Dr. Santisteban just talked about: our family, our individual, and our psychoeducational module components, and how we used each of these components to help this family. And something important to remember is that these three components are not standalone. They all work together, and they feed off each other. So what is done in the psychoeducational module, where it's more didactic and provides context and information, education, and skills to youth and families, is then brought to family and individual sessions to process and to become alive for the family, so they can be integrated into their daily functioning. So these are not standalone, they all work together. So if we think about the family, these are just some of the components in the effort of saving time and to not talk so much about this, but that were central to the treatment of the youth and the family. So with regards to the family, the primary focus of the family therapy was to open lines of communication between the mother and the daughter and to reestablish an emotional connection. So we just mentioned in the previous slide where we were talking about SIFTA, that in the family therapy, our focus is to enhance the protective factors. We want to attend to some critical issues and ruptures, but we really want to enhance protective factors that we know are central and can be really, really helpful to ameliorating symptoms that are bringing the family in. So the experience of the sexual abuse, the mom not being attentive, and the immigration-related separation had badly damaged their relationship. And there were many misunderstandings between them, misconceptions about feelings and behaviors and why things occurred. And this really led to that disconnection. In the individual therapy, the primary focus was with the youth, and that was to increase motivation to engage in treatment. As I mentioned, she said from the start that she was only coming because the mom, wanted her and was making her come. So the first and foremost task was to increase her motivation, her own intrinsic motivation for wanting to be in treatment. And then second, to increase motivation to reduce and eliminate the self-harm behavior, the cutting that had been happening for many years. Once the adolescent became sufficiently motivated, then the individual sessions shifted and began to focus on generalizing some of the skills that were learned, some of the DBT skills that were learned in the psychoeducational modules, as well as, preparing the youth for family sessions, which is also something very important that we use the individual sessions. So how do we prepare a youth to engage in sometimes difficult communications with the family? And that's an important task. And then lastly, we think about our psychoeducational components. And here's where we take a moment to deliver didactic, more context, information, skills, for the family and for the youth, sometimes together and sometimes separately. And as Dr. Santisteban mentioned before, we have an immigration-related separations module. And this was one of the first modules that in our consultation team, we decided was important for the family, because this was an event that had occurred between the mother and the daughter that was greatly contributing to the emotional disconnection and attachment and the lack of attachment between the mother and the daughter. There was a lot of hurt and anger that stemmed from the separation. So we delivered the module and the content to help them understand what is an immigration-related separation and what it can do, what it means to each member of the family, and what it means to the relationship. And so that content of the module helped to create a readiness for the family to process the separation in family sessions and to be able to start to share feelings that were related to the separation, to clarify misunderstandings, and to start to really hear from each other and be open to understanding each of their own experiences, which were very different. The self-harm module is one that we have specifically that's related to youth who are engaging in self-harm. And again, it takes time to deliver important information and education. Much of what we talked about earlier today in terms of risk factors and reasons for self-harm, to open up, again, the readiness to have a conversation within family and individual sessions about what the self-harm behavior means for the youth, and to create readiness for them to be able to work on ameliorating the symptom. We have a module for parenting, which was also critical. We focus here on helping parents understand what stage their youth are at, what are appropriate parenting strategies, and then how to focus on these protective factors that we've talked about: monitoring, communication, general communication, and building attachment. The acculturation module is another cultural specific module that we have that's part of SIFTA. And here, as I mentioned earlier, it wasn't that the gap in acculturation was due to the mother and the parent, the stepfather, not acculturating and the youth acculturating faster. It was opposite here. So the youth had come to the United States most recently and was struggling. She missed her country of origin. She struggled with language even after had been here 2 years when she came to our program. She wasn't integrating in school or with peers. So the acculturation module, again, helped provide context and help them understand what is this process of acculturation and how does it impact each of the members of our family, so that then we can have open communication and work through it together. And then lastly, our skills modules, which are really come from Marsha Linehan's dialectical behavior therapy. And we focus mostly on distress tolerance, emotion regulation, and interpersonal affective modules to help teach the adolescent healthy ways of coping, regulating her emotions, tolerating distress, learning to identify and to manage those surges of emotions and the urge to self-harm that comes. And so, you know, this family was with us for about 4.5 months. They received just about 30 sessions. At around session 12, the youth had stopped engaging in self-harm. She had really taken and become open to several of the distress tolerance management skills from the DBT. She integrated using a stress ball, and mom even helped her order it from Amazon, where she was able to use the stress ball. And also she was very sensitive to touch. That really helped her. And that's part of the DBT skills as well. This is what we talk about in terms of really taking the time to go through all of the options to see what will actually work and is a viable option in terms of helping youth tolerate distress. So for her, pressing ice against her skin, cold water on the face, and again, the stress ball were very effective skills that helped her reduce the urge and ultimately stop engaging in self-harm.
Fantastic, thank you.
So with that being said, I just want to take a minute. We have time left to answer all of the final questions that have come in. We want to take a minute to acknowledge several important partnerships and funders: SAMHSA, the NLBHA, PTTC, and the National Institute on Minority Health and Health Disparities. We also want to take time to really thank our entire SIFTA team at the University of Miami. We have our master's students, PhD students, all of our clinicians and program coordinators who do amazing work for SIFTA and our community, who engage in research and service, and we cannot do what we do without them.
Yes, a big thank you to our student and team here. They come to our program from around the country for the master's and PhD program to learn how to work with Latino families and then contribute to the research. So we're very grateful for that. I know that we need to leave a little bit of time for the team, but we have at least a couple of minutes for questions. I have 2 here that I can respond to, and I don't know if you want to see if there are any others that you think. One is, I'm having a very hard time getting individuals to follow the safety plan. What are any suggestions in following the plan when they are in distress? And you know, this by far, there is no magic wand for this one. It is one of the tough parts of the work. One of the tricks is really, as Dr. Mena mentioned, to be careful not for us to suggest what they might do, but to really take the time for them to think through what might work for them. What are the pros and cons of doing that? Is it feasible? You know, you don't want them to think of something that, you know, they can't do because they can't start listening to music in the classroom, right? So they have to have some kind of strategy that they can use in the moment. And so, you know, spending the time for them to come up with things that are really feasible is really important. In our work, we used a diary card to help kids identify risk moments, risk places, risk people, right? Triggers, and to think through which of the skills that we taught them they might be able to use. And so I think the diary card is really helpful for them to give a lot of thought to what they might be able to, what resources they have at their disposal that they might be able to use in the moment. There was another question: have you found that cultural concerns have evolved over time in the Latino community, or is there still a gap? And I must say that this really often depends on the specific population and city you're working with. We happen to work with a lot of very recent immigrants, and so this is alive and well. Even in long-standing Latino communities in the United States, you see that acculturation, even over generation, continues to have an impact on behavior problems. And so even when it's a matter of, you know, sometimes losing our protective factors over time, right? And so we believe this is really continues to be important. I will confess to you that I'm still trying to get my son to dance salsa, so we have a hip movement problem, but there are just so many levels of ways in which culture is important to us, right? And that we work through things that, you know, we can laugh about, enjoy, that are protective factors. And so we think that they're alive and well, and we should continue to focus on them. Is there any other?
Absolutely. So I have a question here. At what point would you say a child abuse report would be warranted when a client is exhibiting an SSI or SI, and the trigger may be mainly due to parental discord? Of course, you need to know whatever are the rules and regulations and laws for the state that you're in, for your location. But the rule stands that if you know, as it is in Florida, is that if a child is in trouble and is at risk, then even if you don't know and you're not 100% sure, even if you have a doubt, you still need to report. So that's the most on that. Another question was, when I talked about CBT as an evidence-based intervention, what form of CBT? The form of CBT that's been investigated is integrated cognitive behavioral therapy, so ICBT. It's a combination of individual CBT, family CBT, and parent training that has some mixed results. And there's another version called Safety, Safe Alternatives for Teens and Youth, that combines CBT, DBT family treatment, and DBT family treatment for parents and youth. And that also has some evidence, but mixed.
And maybe about trauma, TF-CBT. And
trauma-focused CBT for trauma, that's correct.
Unless there's any other one, I think it's a good time for us to stop. Any other?
There's a few other ones that we'll try to get to because I know we're out of time, but we will maybe type some responses so that we can get them. And let me just advance one more slide so that we share with you all our contact information. So if there's anything further that you would like us to highlight, please feel free to reach out to us.
There's a really interesting question here on does SIFTA include an ACE score as part of the assessment? And that's a great question because we really tailor the assessment to what we think is particularly salient in the population. We really, as we mentioned, have been using the Hispanic Stress Inventory so that we can identify stressors and that it can inform the intervention. But we believe that things like ACE and other measures of stress and of adverse childhood events, it can be very helpful in terms of informing treatment.
Absolutely.
Thank you for that question.
Thank you all very much. It was great to spend the afternoon with you.
And we'll turn it over to our colleagues.
Yes.
Thank you, Dr. Mena and Dr. Santi Esteban, for this wonderful presentation. We have learned a lot, and I think the QA and chat is on fire. So thank you so much for everything. Here is the contact information from our center. So feel free to contact us if you have any questions. Here is our contact information. Next slide. Here is the satisfaction evaluation site. So please, this is important for us. Before we close the presentation, we want to remember everyone that in the chat we have the National Suicide Prevention Lifeline number. If you need to reach out for help. Also, we have la línea de teléfono nacional de prevención de suicidio en español. And also we have a few resources from SANSA that you need help and you need to talk to someone after the presentation. Feel free to reach them, please. Once again, thank you so much for joining us. And Dr. Mena and Dr. Santi Esteban, thank you again. What an honor. Thank you so much for the
Muchas gracias, un honor.
Gracias.
Thank you, it's been wonderful.
Once again, thank you for joining us during our webinar titled Suicide Prevention, Identifying and Modifying Risk Factors that can lead to suicide attempts in the Latino youth. Enjoy the rest of the day.